20 years ago, a diagnosis of multiple myeloma meant 3 to 5 years to live. Today, patients are living for decades with CAR T, bispecifics, quad therapies, moving from trials into practice. Patients are finally gaining real access to therapies unthinkable just a few years ago.
Down with Dex.
Please, guys, it's all hands to the pumps.
Every patient should have that optionality.
We're closer than ever to transforming myeloma into a chronic disease and maybe even asking, can we cure it? I'm Dr. Tania Small, and in part 2 of our multiple myeloma episode, we continue the conversation with Dr. Paul Richardson, Dr. Joe Mikhael, and Dr. Mecide Gharibo as we explore the science, innovation, and human impact behind the next wave of breakthroughs.
Now let's get started.
I don't know if it's a provocative question or not, but you talk about screening. So we think about colorectal cancer. We do colonoscopy. If you see a polyp, you're able, you look for polyps. You're hoping to catch it before transition. Breast cancer, right, before it transitions. If we talk about screening, particularly you said African Americans or people of African descent, twice as likely to be diagnosed with myeloma, should we be screening all?
Well,
right, people of African descent.
Yeah.
And my second question to that is, okay, you screen, you find out someone has MGUS.
Yeah.
Then what?
Right. Well, I want to acknowledge one of my superb colleagues, Irene Gabriel, who leads our Center for Early Detection and Intervention. It's called SETI for short. And she and Betsy O'Donnell and a number of other colleagues have this incredible effort where they've actually, the PROMISE study has been with us for a while.
Yes, that's about PROMISE.
And the issues there, I think, are being very, very appropriately and actively addressed. I also think we're seeing therapeutic advances in this early myeloma precursor world. For example, the recent ODAC decision to allow daratumumab as an appropriate antibody to consider. Now, we're obviously still waiting for an FDA decision, but what's very interesting is there's a survival benefit to that early intervention, which is fairly innocuous. I mean, monotherapy with daratumumab, in my experience, is very straightforward, and fortunately not associated usually with challenges. Although I must be honest, the challenge for me strategically is if you intervene with dara early.
What then?
Exactly,
Yes.
and are you going to be buying issues, because to me, intuitively, a quad makes more sense because you're addressing the heterogeneity we've been talking about. In the event, pivoting to your question, Tania, which is an excellent one, I think at-risk populations absolutely benefit from screening. And I think the issue simply is there that you have the opportunity to identify at-risk populations, and in those patients you should screen. And I think that to me makes intuitively great sense, because then this diagnostic uncertainty that Joe mentioned, which is very real, becomes less of an issue. And a stitch in time will save 9, to use an old metaphor.
To add to what you said, Paul, and I wouldn't disagree per se, but where I would push back just a little bit is we are hopefully on the verge of getting the answer to this. So we've done the largest screening study of myeloma on the planet in Iceland.
Interesting.
Now,
yes.
the iStop study, Iceland screens, treats, or prevents multiple myeloma, has recruited over 85,000 patients over the last 5 years, where the key question was, does screening save lives? Because when you gave the 2 great examples of breast cancer and colon cancer. I mean, not to get too personal or TMI with the crowd, but I had my colonoscopy last week. My father died of colon cancer, so I have colonoscopies every 3 years, and so I understand it. This is deeply personal and professional, but it took us decades to figure out when do you initiate colonoscopies? When can you just use something like Cologuard? How frequently is it different for men versus women if you have a family history or not? Same with breast cancer, right? Before we started just randomly doing mammograms, it was very strategic. So we're in that process right now with multiple myeloma. Now people say, Iceland, and that's pretty white, right? But if the principle can be proved in that population, how much more valuable it is, will it be within this population? And I think something like the PROMISE study, which I had the privilege of designing with Irene, I think is going to bring us there. So the way I approach it is, until we have that final answer, which will mitigate the insurance issue, which will help answer your second question about What happens if you do detect MGUS? And we follow these people. We've initiated a study. Pete Voorhees, Minister Bhutani, and their team in North Carolina just started the CHAMP study, where we're looking at this same exact phenomenon, but specifically within the African American population because of the incidence is twice as high. But let's not forget, it's diagnosed considerably younger in the Latino American population. So often that gets missed. So we're going to have to decide what is the right age in each of these groups.
Joe, and I really want to build on this because one needs to be very clear about this. There are other at-risk populations, and family history is very important. But for example, we're recognizing that the disease is grossly underestimated in the Middle East. In one exception, in Israel, with a highly sophisticated healthcare system, it is very clear that myeloma is significantly more common in people of Israeli heritage, and in particular of Ashkenazi Jewish descent. Less so in the Sephardic and the Mizrahi, but the reality is it is more common. And so I think as we think about this, we need to be very clear about the complexity of this and the breadth of it, that it exists in African American communities, Latino communities, and in people of Ashkenazi Jewish descent. And just as we have BRCA1, BRCA2, we're looking for these gene signatures that may give us clues. But I think you touched on it beautifully, Joe, because family history matters. We used to think familial myeloma was very rare. We realize that's not the case, and that there are certain B-cell malignancies that like to cohabit with myeloma, be it CLL, non-Hodgkin's lymphoma. And interesting enough, as we think of the Ashkenazi population, Waldenstrom's is significantly more common in people of Ashkenazi descent. It's no surprise then that myeloma is, because guess what? So is B-cell lymphoma. So as we think about this, it becomes a lot more complex equation. And I agree with the idea of screening at-risk populations, Joe, and I think we should throw that net nice and wide because we're realizing that, that's true. And then, of course, you mentioned another key point, Tania, which was exposures. And I think we've realized that is very relevant too. So I think into that net of screening comes exposure, because just as we screen lung cancer patients if they're heavy smokers, there are unfortunately people in our world who have been heavily exposed to certain things. And for example, again, underappreciated fact, myeloma is more common in woodworkers, carpenters, joiners, and people who work in the timber industry. Probably related to a very interesting, rather nasty looking component of wood called lignin, which looks a bit like an asteroid under electron microscopy, but it's highly pro-inflammatory and irritant. We know that in professional firefighters, this disease is more common. We know those exposed to nuclear radiation. We also know that obviously we have the herbicide story as paradigmed by Agent Orange in Vietnam, but we also know there are other factors that are involved. So I think as we think of screening, population-based analysis is key, and equally also exposure-based as well.
I think one thing I do want to add on, we know that primary care physicians are struggling with keeping up with all of the screening recommendations.
Right.
I mean, if you think about patients that smoke right now, majority of them are not being sent for screening CT scans, right? And we know that can save lives. So I think we have to think about, once we get the data where there's a clear guidance about who should be screened, I think we should think about how do we make that adoption to be seamless. So think about AI. Allowing things to be incorporated into the EMR, but the EMR actually can give the alert and say, this patient needs to be tested for X, Y, and Z. And I think that's going to set us up for success.
As we speak about modifiable risk factors, just curious to get your thoughts. Number one, what are they? Because a lot of times we don't talk about this as, through your training, you don't talk about diet, exercise, and those things. But now, you think through ASCO, you think through a lot of the congresses, we are talking about that. The studies are finding diet, exercise, what we eat, how we eat, weight, all of that has an effect on transition from even MGUS and smoldering into myeloma, and also how we respond to therapy. So curious to get your thoughts. What are the modifiable risk factors, and how are you teaching your residents?
So that's a fantastic question. So there is no doubt, by general observation, when I have seen patients who are more active, who are intentionally exercising on a regular basis, that it improves their outcomes. And I think it has a lot to do with, as you saw from those meetings at ASCO, has a lot to do with tolerating therapies, being able to be independent, not developing pneumonias and other things we know our myeloma patients are prone to because they're sitting down or lying in the recliner all day long. That I think, to keep it simple, the body was designed to move. Historically, we're told our myeloma patients, oh, no, you have bone disease. You can't do anything. You can't lift a weight. You can't do it. And so developing a very targeted exercises that even myeloma patients with bone disease can do. Similarly, I noted earlier, probably the most modifiable risk factor outside of the exposures that Paul shared with us in myeloma and most cancers is obesity.
Yes.
And it has to do with inflammation. It has to do with so many other features that we haven't quite figured out yet. There are some myeloma-specific studies. I'll call out my dear friend and colleague Irvi Shaw at Memorial Sloan Kettering,
Yes.
who's doing the Nutrivention
Yes.
study, where they're taking patients with earlier stage disease with a dietary intervention to see if it may slow the progression. I think the more Mediterranean style diet is where we have greater evidence, at least, and hopefully we'll have more, is important. And then the very last point that I always like to add, because people don't think of it as a modifiable risk factor, but I do, is the importance of communication between the patient and the healthcare team. We have demonstrated unequivocally, when you have that strong connection between the patient and the healthcare team, and we allow more communicative efforts, whether it's through the medical record or other means, that trust is built, more symptoms are going to be shared, more likelihood of being adherent to therapy, and even more likelihood of going on to clinical trial. I think that improves lives. I say to my residents and fellows all the time, if you could add another drug to this patient and it would improve their quality and quantity of life, would you add it? And they're like, of course. What if I told you it was actually free? And they're like, oh, of course I would add it. Well, what is it? What is it, Dr. Joe? And I say, it's your ability to communicate effectively with that patient.
Yes.
And I know I'm biased because I seek to be a communicator, I try, but I think in the clinic, as opposed to just being focused on the computer screen and typing your note as you're speaking to, is there a patient in the room? That becomes inherently important.
Yes. No, I 100% agree with you, Joe. I think in terms of modifiable strategies, you touched on it, Joe, and I love Mecide's view on this as well. Inflammation is the way I try and center it for my patients, because there's no question that exercise improves your ability to handle the the oxidative stress that is generated in the absence of exercise. So, free radical production is mitigated by everything that you do with exercise. So I try and center it for my patients and explain it and say inflammation matters. And then I bring it back to the obesity question, which is, of course, if you have too much visceral fat, your free fatty acid balance is absolutely upside down and you're pro-inflammatory. So as we educate around that, I also talk to them about the importance of diet in the context of the microbiome, that there is actually a vital construct, which is your gut. And obviously in our patients, we face the challenges of lenalidomide-related diarrheas and the sort of pro-inflammatory stresses that we see in our patient population that lead to GI disturbance. So we try and bring it all together. And so we actively pursue weight reduction. We really bring our steroid doses down super fast because they are a real counterbalance. They're our biggest enemy in some ways and our greatest friend in others. So we're very proactive about it, Tania, because you're absolutely right. It is such an important part of what we should do, and we seek to do it.
So I'm going to now move into tumor microenvironment, because we know that drugs do not work in a vacuum. Right. And a lot of discussions that we've been having, especially over the last 5 years, really honing in on this tumor microenvironment. What have we learned over the last, I would say even 2 to 3 years, about the tumor microenvironment when it comes to multiple myeloma, and how do we target it?
So complex. I mean, I think what we realize is one critical thing about myeloma and the microenvironment is that the neighborhood is everything, right? Yes. Be it immune, be it structural, be it otherwise. Let's not forget, we cure lymphoma. Why? Because typically lymphoma doesn't like to hide out in the bone. The bone, for example, is a key sanctuary site for myeloma. So we've had evidence throughout the natural history of myeloma that the neighborhood truly matters. It's worth noting that way back in the 60s, if you looked at an autopsy series, sadly, of patients with myeloma, almost over half of them had involvement of the liver and spleen. This is a reticuloendothelial disease. One area of the neighborhood that I think has not been neglected but hasn't had as much focus as it should have done is the vasculature in the endothelium. That's one area that I think we need to explore more, both therapeutically in terms of efficacy but also toxicity. Second of all, I think the immune microenvironment has now become the real hot topic, and the whole idea of immune exhaustion. And then third, we still must not forget myeloma bone disease, because that really matters. Joe touched on it beautifully about it being a source of morbidity. It's also an incredible barrier to cure. It's a sanctuary site for disease, which we mustn't forget, because ultimately, as we think about curative strategies, it's going to involve engaging that whole concept of the tumor microenvironment.
No, I think you summarized that really well, and that's where I'm excited to see the emerging data coming from the cell mods, which have that immunostimulation effect and seeing increase in T cell subsets, NK cells, and they're able to penetrate that microenvironment and modulate potentially there, where there are tumor suppressor cells that lead to, clonal evolutions of the plasma cells and progression of the myeloma potentially. So, and the T cell exhaustion, as you mentioned.
Yes.
And it's almost taking us from, if I can use the phrase, from the microenvironment a little bit to the macroenvironment from the immune standpoint. I mean, I think we've always known that myeloma is not just about the tumor, right? It's about the environment in which it lives. Not only the environment, which is in how it takes over that. Sometimes I use the analogy with patients. I say, it's like the enemy has entered the building across the street, and it hasn't just lived there. It's now taken over the machinery of that building. It controls the Wi-Fi. It controls the water. It controls the electricity. So instead of just going and bombing the building, right, the old school way of attacking cancer, let's go in there and actually take control of the Wi-Fi. I mean, you turn Wi-Fi off, my daughters are useless, right? You turn the power off. You turn the power off. You turn the lighting off. Like that sort of concept. But to take it a dimension further, if I look at the heterogeneity we've been describing through this whole discussion of myeloma, there's the heterogeneity of the biology of the disease, but there's also the heterogeneity of that person's environment.
Yes.
Right? So why do I have two patients that biologically, at least let's say from all the advanced testing, I work at a genomics institute, right? We can look at every tiny mutation, every change in the myeloma. Why do I have two patients that seem to be exactly the same that way?
Exactly.
Maybe even the same age and other comorbidities are identical. And yet one of them relapses 6 months after treatment and one 6 years. There's something about their immune environment, the interaction between their inherent B cells and T cells that really make it different. And so we've learned, as you're asked in the question, the last few years, that as we treat people, that all of a sudden becomes really important. Is the T cells exhausted? Can we give, as Sargalonio said, a cappuccino to their T cells, to burst, to wake them up a bit like Paul did with his cappuccino today? Is there a way of doing that?
I needed it.
But that also may help answer some of the questions about how long someone has to be on treatment.
Right.
So ultimately, my sort of nirvana is to say, okay, here I've treated this patient for X period of time, and we're debating, can we or should we continue, escalate or de-escalate therapy? I'd look at three things: their MRD status, which speaks to their response to therapy, their risk status, which speaks to the biology of the disease, and then thirdly, their environment status. What can I, and we're not quite there yet, but there are these tests being developed that can I interrogate, as it were, their B cells and T cells and see how effective they are? How likely are those Bs and Ts to keep those prone to become malignant plasma cells under control, or those that aren't there and those plasma cells will recur? So I'm not sure, we don't have a commercially available test for this, but if I could be Joe Prophet for just a moment.
That was be my next question, so
in the future, I would love to be able to tailor therapy based on that. I could look at that patient and say, you know what, your Bs and Ts need more time to recoup.
Right.
Let's not stop treatment. On the other hand, over here, your Bs and Ts are working really well. I think we can stop therapy and your disease will remain under control. I think that may be part of our future.
And also, if I may, to flip onto the therapeutic side of that one, we've already touched on the promise of CELMoDs, the use of Selenex or other drugs in that setting. It's important as we think about immune therapies to recognize, for example, in the antibody drug conjugate space, we've realized where we were concerned that there would be immune exhaustion, that's actually not the case at all. And that actually there is immunogenicity that's intrinsic to those mechanisms that allows us then, so Joe, to your point, your patient is B and T cell exhausted, but needs something that doesn't depend on that. We've got the toolbox combined, say, with a CELMoD, combined with other drugs where we can bring that in. And those, I think, are incredibly important considerations as we think about the value of sequencing. And I love the way you framed it, Joe, that when you think about sequencing and what you best use, understanding that milieu that the patient exists within and can fight the disease within is absolutely essential. And the good news is we have tools in the toolbox to fit that scenario, as opposed to having said, God, we've got nothing. And thank goodness we do have things to meet that challenge.
And Tania, I leave it entirely to you that I suspect that you are going to create the B and T cell spa for our patients,
I love
right?
that.
Can you imagine the Tania Small spa, where you come and bring your exhausted Bs and Ts, and we will
give it a little
rejuvenate
bit
them.
rejuvenation. And with that, I'm going to ask them, Mecide, who is our hematology drug developer and delivery here. What are you excited about in terms of the new pipeline coming to fruition? Are there specific modalities or studies that you're excited about beyond the B and T cell spa that we're working on?
Absolutely, Tania. There are actually several pivotal phase 3 registrational studies that's going to have a readout in the next 1 to 2 years in the early relapse setting. So we talked about iberdomide with Excalibur relapse refractory study, and then we have mezigdomide, Successor 1, Successor 2. And then we have several of the bispecifics, right, in the second line plus setting. And I think those studies collectively is going to really be very impactful for us to see the readout. And then again, have the optionality for patients with different modalities. And but then the question about sequencing again.
It's going to pop up again. It's going to be a forever question, which is not a bad thing, right?
Right.
More tools.
Right.
Yeah.
But tons of exciting future data in the next 1 to 2 years that's going to potentially change the treatment landscape in early relapse.
Yeah.
I mean, I think similarly to me, I think it's the 202 of a lot of these 101 therapies that we've developed, meaning can we now take them to another level? Like you've described the cell mods as being the sort of the 202 in my mind of what we've been able to do with immune modulation to take it a step further. The next generation of CAR T cell therapies are now being developed that may potentially have as much efficacy as the earlier ones, but actually with even more safety, especially for some of those neurological things that we're challenged with, especially the late effects. Similarly with bispecifics, going towards bispecifics that don't need step up, that don't need admission, that can be given once a month right off the start, or even trispecifics that have a greater affinity to the tumor cell and have less offsite effects. So to me, it's hard to pick one exactly, but this whole notion of saying, okay, we've proved in principle that we can immune modulate, we can do a CAR T, we can do a bispecific, we can even some of these small, simple, easily delivered molecules. Can we make them even better by providing the same degree, if not higher efficacy, with considerably more safety? I think that will give us the double win of not only providing safer and more effective therapies, but then we'll make it more accessible to others, because we ultimately would love to be able to provide these. I mean, I love the idea of an off-the-shelf CAR T. I know that allo CAR T has really struggled for many reasons, just from even the technology side of it. But imagine if we could just, go to Costco. Okay, my wife thinks I'm addicted to Costco, but go to Costco and buy some T cells. I mean, obviously that's not going to happen. But the point being that instead of going,
I thought he was going to say a different type of place.
But instead of having to go through the T cell collection and the challenges, and Paul mentioned earlier the delays of all those, I mean, we're not quite there yet, but looking into the future, to me, that would be so valuable, because we have seen the value of an easily delivered off-the-shelf treatment already. And our myeloma patients are older. They often live in more rural areas. Worldwide, we're talking about not just Indonesia, but so many countries where it's so inaccessible that we really, we can't depend on this inordinately complex, multi-step, inpatient requiring a process that ultimately, if we could deliver it more easily, I think it's going to change the world, and I'm thankful for that.
Well, I build on that. I'd say we have to just to step back a little bit to say myeloma, to quote my colleague Cliff Moe, has become a tale of two cities. And what I mean by that is that we're doing great in a significant number of patients, but we mustn't forget this 1/3 of patients who are either at diagnosis or become functionally high risk. So this remains a very challenging area, and we need to continue to really deliver therapies. And I love what you said earlier, Mecide, about this being the wide open area for new agent development. So I think as we think about this, what I'm really encouraged by, Tania, is that we have existing options that are already there. We talked earlier about the antibody drug conjugate space. I mean, let's not forget, in DREAM7, the median overall survival estimate is in excess of 3 years. It's about 3.5 to 4. That's comparable to CARTITUDE-4. So please let's not forget that, because that is a very simple outpatient strategy incorporating one of our good old war horses, bortezomib, and at the same time an antibody drug conjugate that generates immunogenicity that synergizes with the immunogenicity of proteasome inhibition. And I honestly think that Joe, you touched on this earlier, that we've got this wealth of opportunities. What I see us doing is refining those combinatorial strategies and having a wealth of opportunity for each individual patient that meets that need. And I think this is so important because at the end of the day, refining the existing toolbox as well as new advances remains such an important strategy because you touched on this earlier, Joe. Healthcare jurisdictions are resource limited. We have to be aware of what that means. We have to be real about what that means. And so I'm particularly excited by the fact that we've got oral agents, the cell mods. I also love some of the existing platforms we have already, the antibody drug conjugates, for that matter. I firmly believe in the peptide drug conjugate concept. I think alkylators matter. I think we've got existing small molecules. We've got P3100 inhibitors, all sorts of things, KRAS inhibitors. We've got an incredible wealth of science that's going to inform us going forward. So I love the idea of the immune therapies and getting better CAR-Ts that are truly miraculous. I also think the bispecifics are going from strength to strength and the trispecifics the same. But please, guys, it's all hands to the pumps because that's, I think, what we must have for our patients above all and to meet the challenge of what myeloma really is.
I'm going to do a quick round robin.
Yeah, of course.
Starting with you.
Right.
What is, one of the old beliefs of multiple myeloma, old dogma of multiple myeloma that needs to be retired?
A retired concept in myeloma is, I think, what I would call therapeutic parsimony. What that means is, in a frail elderly patient who's very sick, you can do a monotherapy or a dual treatment, but you mustn't give them a triplet or you mustn't give them a quad. I think that's a misunderstanding. I think the construct is that you use components of each at much lower doses to generate more. So I would love Joe and Mecide's view on this because it's a complicated, complex concept, but this idea that the frailer older patient can only tolerate 2 drugs or even just one, recognizing that obviously has to be tailored. But the reality is actually morbidity and mortality associated with disease can be grossly underestimated and misunderstood. It can be seen, you have a patient who literally 3 months before was golfing, swimming, and everything. They've come in, they're in their 80s, they're disabled by their disease, they're deemed to be frail, therefore we're therapeutically cautious. I think that's an old dogma that I think we need to rethink because we're not giving chemotherapy, we're giving targeted biological therapy, and literally you've got the synergy of the Army, the Navy, the Air Force, the Marines, the Coast Guard, and the Special Forces. That means you don't just use one arm, you use them all together. So I hope that's interesting, but that's kind of what I would think.
I was just going to say the same thing, Paul. There's an age prejudice. Once they hit a certain age, if it's 70 or 75, there's this notion that those individuals may not tolerate more combination therapy. So even being referred to treatments like CAR-T therapies. And to your point, like there's a thoughtful approach to how you can do it as a stepwise fashion. Maybe you start off with 3 drugs and then you add your 4th one, right? But I think every patient should have, or at least be given that optionality, and then it being a shared decision making. And you can always pause and stop and redirect depending on how the patient's journey goes with those initiation of treatment.
Absolutely agree.
3 words.
Yes.
Down with Dex. So I had the privilege of writing an editorial with the incredible nurse practitioner that I work with, and it was in response to as an editorial that was accompanied in blood by the article, the main article that Rahul Banerjee, one of my mentees, my incredible doctor up in Seattle, wrote, where they looked at 2 upfront SWOG studies and compared the outcomes of patients who had reduced their dose of dexamethasone versus those that did not and did not show a difference in their outcome. So the dogma has been, you'll take the dex and you'll like it, right?
Suck it up.
I think that dex, that dogma is being broken. And very pragmatically for clinicians listening in, instead of saying we're going to give 40 milligrams every week indefinitely, and going back, of course, it was a patient at the IMF, Mike Katz, who convinced Vincent Rajkumar and the ECOG clinical trial community to say, can't you do a study with less dexamethasone?
Yeah.
And that's where we went from high dose dex, which was 12 out of 28 days of 40 milligrams, to low dose dex of 40 milligrams once a week. We're the only people on the planet that would consider 40 milligrams of dexamethasone once a week to be low dose, right? So what I'm saying is we need to be moving to even lower, if not optimal dosing of dex. We love dex because dex reduces, has an anti-myeloma effect. Dex reduces infusional or administration reactions. Dex reduces nausea, and dex reduces pain. But most of the primary effect of that is within the first cycle or two, and then we go down with dex. We dial it down over the subsequent few months, and so that patients can be off of it at 4 to 6 months after they've started. I think we're gonna break that old stigma that it's dex forever, and now it's down with dex that we only give for the first few cycles.
I think, Joe, if I can just have one little vignette to that, I think it's beautifully said. And I think the other thing to remember for our clinicians listening is don't forget the value if you've got someone who's getting a lot of psycho-emotional difficulties with even the lowest doses of steroid, be it dexamethasone. Never forget methylprednisolone, solumedrol, which does not cross the blood-brain barrier. And that can be a very useful substitute because essentially that emotional piece, which you have to ask the spouse about, not the patient, because they do not have insight, typically. You have to say, how is he or she doing? And you get the truth here and the hypothesis here. The fact is that solumedrol I've found a very useful tool to avoid that blood-brain barrier issue. And just a vignette for the clinicians because it's sometimes underappreciated and it can make a difference.
Listen, with this, thank you so much for an intriguing and engaging conversation. This was fun. Dare I say one of the more fun ones that
Of course it was. Of course it was.
And I mean, again, just thank you for this dialogue, for this unfiltered dialogue, for this bold conversation, for pushing the limits on how we're thinking. And I'm sure those listening will take away a lot from this. And before I end, I usually ask people, and this to me is one of the most important pieces, who are you fighting for? And I'll start with you, Mecide.
I'm fighting for patients today, patients in the future. To me, any incremental improvement in outcomes is what I'm fighting for.
Yeah.
And for that goal of future cure.
Future cure.
In myeloma.
Yeah. Yeah.
It's hard to top that, of course. I get very close to my patients, and I love that. I think that's maybe another modality that we've broken is that we have to have this distance. I mean, yes, there is a professional relationship, but I love getting very close to my patients, and to me, it's such a privilege. And so obviously we ultimately fight for them. And Paul and I have reached stages of our career where I'm also fighting for that next generation of myeloma doctors because I want them to succeed. I'm happy to step into the background to let these next generation come. They are brilliant. Despite what we might think about this next gen, we have some brilliant and highly motivated physicians from across the planet because I want to not just fight for my patients, I want to fight for the patients across the planet. I mean, that's the I and IMF, of course, the international component. There are so many people today not being diagnosed and not being treated appropriately on this planet that I really think we have the opportunity, if we can culture the right mentorship in our junior faculty around the world, to have even a greater impact, more than what I or a person could ever do, that we can do in a combination way, obviously in a way all together.
I think beautifully said by both Mecide and Joe. I think that our patients above and all, and I've always felt best research always puts the patient first. And by doing that, you can really you don't lose your path. I think you're so right, Joe. Our teams are everything, and that team doesn't just include my physician colleagues who I'm privileged to work with, but also everyone in our team. We're very nurse strong. We're very clinical research coordinator strong. We build a culture of working together at every level so that everybody feels truly valued. And I think that kind of approach to our research and to our clinical practice and to our patients continues to really deliver. And one thing I do feel passionately about and very strongly about, given events of the summer, has been the importance of us in partnership with our pharma colleagues, because ultimately a drug approved means a drug helps the patient.
That's right. And one of the things to your point earlier, we talk about here in the show, and part of the tagline is patient-driven science, where the patients are the ones driving our science. And we can't forget that's why we're here. That is our why, our universal why. And we all have to hold hands. So whether it's in the academic centers, the community, the regulators, the payers, the pharma company, we have to come together to hold hands. And you guys have already broken the ceiling, topped what we thought could be possible. Imagine if we come together even stronger to hold hand and how much further we can push. So again, thank you all for all the work you've done for patients, all the work you've done for the community, all the work you've done overall for healthcare. And thank you for being here today. Thank you.
Thank you very much. Thank you for having us, Tania.